A very good morning to you, ladies and gentlemen. So on behalf of the Sri Lanka College of Paediatricians, let me extend a very warm welcome to all of you who have joined this webinar. As you know, as Sri Lankans, we are all facing many challenges, and the children of this country too are greatly affected. Their education, nutrition, and safety has been significantly compromised. The predictions are that the country would face more severe food shortage in the coming months. So the College of Paediatricians, as a responsible professional organization whose primary interest is the children of Sri Lanka, feels that it's time that we work together with all stakeholders to try and minimize the short-term and long-term outcomes that inadequate nutrition would result in. So this seminar on nutrition, challenges and solution is the first step of which this is. Today, we have a very eminent panel of speakers who will share their expertise. And we have 5 presentations that have been lined up. We are planning to have a question and answer session to clear any doubts, if there are any, at the end of the session. So the participants can ask questions directly, or if you wish, you can type your questions in the chat box, and then we can direct them to the relevant people. So can I kindly request you to have all your mics muted while the presentations are going on, so that we will be able to have this seminar in a very successful manner. So without wasting much time, I have great pleasure in asking Professor Narada Varnasurya, Senior Professor in Pediatrics at the Sir John Kotalawala Defence University, to start his presentation. And he will be talking about an overview of the prevailing nutritional problems in children. Over to you, sir. Thank you.
Good morning, Hishan.
Good morning, sir.
I can't share the screen yet. Please, can I share the screen now?
Yes, you can, sir.
Right, okay. Colleagues, friends, and students, I thank Professor Gwani Renege and the Council of the College of Pediatricians for having invited me. In the 20 minutes allocated to me, what I hope to do is a brief bird's eye view of the nutrition related problems in children, and then look at the intergenerational effect using the life cycle approach. Then also view briefly the social determinants of these problems and their implications in general for society. And finally end up with a sort of checklist of what we as pediatricians could do briefly. I will not be going into great detail because a very eminent panel of colleagues will be filling in on the details later on. So let me start. I think all of us are familiar with the, I must say as a comment, I'm very proud to remember that 48 years ago in 1974, at the peak of the most severe epidemic of malnutrition that we saw in our country, as a lecturer in pediatrics, I made a presentation on the prevalence of protein-calorie malnutrition in children to the College of to the then Sri Lanka Pediatric Association. Of course, at that time there was a major paucity of data, but today the situation is quite different. So coming back to my slide, as we know, these are the 5 main nutrition deficiency disorders of public health importance. Energy protein malnutrition without doubt takes the top place, the macronutrient deficiency. The others are micronutrient deficiencies. Out of these, I think Renuka would tell us probably iodine deficiency has become less of a problem in our country with the universal salt iodization program which we have had in situ for some time. Zinc deficiency, on the other hand, has come up in the list of concerns. Then there are other conditions which are related to food and nutrition which are important in childhood. Low birth weight takes number 1. I think from the time Devika Jayasuri and Priyani Soisa presented their seminal paper on birth weight of Ceylonese in the early 1970s, the low birth weight rate has not come down very significantly. I was told by Renuka that even now it is about 17%, but I presume that the percentage of IUGR, which was very high when Professor Priyani Soisa studied it, nearly 80%, may have come down with better neonatal and pediatric care. Now, childhood obesity, as all of us know, that we face the double burden of malnutrition. While we have not eliminated the nutritional deficiency disorders, we are having the disorders at the other end of the spectrum, including obesity, metabolic syndrome, and the related diseases like diabetes. And then all of us know that through especially the now, the Barker hypothesis, the relationship between this and adult diseases, and the fact that many of these diseases actually have their onset in childhood and adolescence. And although preconceptual folic acid has reduced the incidence of neural tube defects, that has not been completely eliminated. So I have included that also in the list of problems. And then, as you know, food contamination, both biological and chemical, continues to be a problem. However, I must say its importance was probably blown out of proportion without scientific evidence, and it actually caused some harm to our general economic development in the country. But we have to recognize that it continues to be a problem, and in the emerging situation, this might in fact be aggravated, both biological and chemical content. Food allergy has been a problem that we have seen as clinicians, but I don't think there has been a great increase. There was a reported increase in this problem when genetically modified foods were introduced in some countries, but I don't think we have noticed the phenomenon in Sri Lanka up to now. I may be wrong, and others may correct me if I'm wrong. Now, I think this is the most important slide today. This was sent to me recently by Dr. Renuka Jayatissa, who, as the head of nutrition at the Medical Research Institute, during the last 20 years has been supplying us with really high quality data based on which we can both plan our clinical management as well as the nutrition and health planning. The data she provides is absolutely sound. And as you can see, from the time I referred to in the 1970s, when we had both stunting and wasting, wasting being the result of acute energy protein malnutrition as denoted by weight for height, and stunting being the result of chronic energy protein malnutrition denoted by height for age. And underweight, of course, is a composite where both wasting and stunting can contribute to underweight. As you can see, there has been a steady decline in stunting. In fact, our stunting levels are quite low now, almost up to 12.7. Underweight also has reduced, but not as much as stunting, because wasting, as you can see the red line, this is the problem. This has remained a constant from 1975 up to now, hovering around 12 to 17, right? Now, this shows that all the development that has occurred in this country, all the interventions have not reached at least a decile or more of our population. The people who are in the poverty trap, this group has not been touched. And this is the group that becomes most vulnerable in situations like this. So we can, whether this 12.7, which was the last figure in 21, rapidly needs to be seen. Maybe we will have some information during the discussion of that. Now, as I said, unlike in 74, we have excellent data. And this was again forwarded to me by Dr. Renuka. It's the nutrition status and gaps in the diet of Sri Lankans in the pre-economic crisis period. This is a beautifully documented report. I recommend that all of you are interested to read this, and it is available online. Now, what I want to stress as a clinician is, although we do look at the anthropometric data and the anthropometric statistics, as clinicians, we have to look at it from a clinical point of view. I know a recent communique by UNICEF on the nutrition status of Sri Lanka said that we have been the #2 highest country for malnutrition in the world for quite some time. I was quite astonished when I heard that, but I realized that what he was referring to was our very high wasting rate. The wasting rate is very high compared to even sub-Saharan Africa. But that is somewhat of an artifact, because in sub-Saharan Africa, stunting and wasting both occur to the same extent. So when stunting becomes less, there is an apparent increase of the wasting compared with countries where both stunting and wasting are there. So this was misinterpreted as saying that our nutritional status is worse than even sub-Saharan Africa. No, when we are, as clinicians, what we are talking about is the decompensated severe acute malnutrition. In fact, there was a big ha-ho made by UNICEF and the group even about moderate acute malnutrition, advocating that we ready to use therapeutic food even in those patients. I think I disagreed with that even at that point. I think what we have to be concerned about is children like this. This is from Ward 1 in the 1970s, severe marasmus, a walking skeleton. The moderate energy protein malnutrition is seen on the right. And then this picture shows the one on the right top corner is the marasmic kwashiorkor. Upper half looks like marasmus, but in the bottom you can clearly see the edema of the legs. And then we have the classical kwashiorkor. These two pictures are not from Ward 1. So this is what we have to be concerned about. I must say, I saw most kwashiorkors in the 1970s. In fact, I think we have analyzed admissions to Ward 1. We had probably 30 patients with severe acute decompensated malnutrition per year during that time. And after that, I saw a few patients soon after the war in the displaced camps at Chetikulam and Vaunia. But I'm told that sporadic patients with this condition are being seen even now in some base hospitals, etc. I think the pediatricians in the periphery would know more about this than me. But I hope not, but I have a feeling that this might re-emerge in the current setup. Of course, these are again two conditions we do not see any longer. Keratomalacia especially, hardly, and even Vito spots, its precursor, I have hardly seen during the last 10 years. But we used to see this very frequently. In fact, I remember when I went on a, with the group soon after the tidal wave in Batiklo to Katankudi, almost every other child had Vito spots because all the refuge, they were existing on dry rations. Endemic cretinism due to endemic goiter is now eliminated with iodine. Probably we still have congenital athyroidosis, but that is also being detected now with our screening programs. Very quickly, I think the most important slide here in a way is this slide, which is about 10 or 15 years old, but it is the WHO's estimate of how much of mortality in childhood, especially infective mortality, has malnutrition, the most important cause of secondary immune deficiency, in the background. Unfortunately, this statistic is not properly estimated now, especially because most clinicians fail to instruct their house officers to put malnutrition as a background factor in the death certificate when they are doing the death certification. But I think the figure is certainly not 55% in Sri Lanka now, but we have to be aware that malnutrition is a major cause of infective morbidity, especially GI and respiratory infective morbidity, and it contributes to mortality. So this is what might re-emerge in the present setup. And then, of course, we continue to be concerned about low birth weight, as you can see the preterm on the extreme left. And the one that we are most concerned about is the IUGR in the center, the one which is linked to adult disease in later life through the Barker hypothesis. So let us look at this slide. Just pay some attention to this slide, which shows the intergenerational effect, taking the nutritional life cycle approach with the low birth weight baby, not only morbidity and mortality in the perinatal period, but increased risk of adult disease. Then it predisposes to malnutrition in later life. And then the most important thing is the stunting of the girl child. when the girl child gets stunted, that is the major reason for continued high low birth. And then the other point in this cycle I like to highlight is about the older people, because the older people are the ones who are providing care to our children, especially with working families, the grandparents. So in a situation like this, when the older people get malnourished and ill, the capacity to care for children goes down, and then that makes children much more vulnerable. So these are all interconnected. I think this is the really, really important diagram, the conceptual framework for malnutrition, which UNICEF proposed in about 20 or 25 years ago. I think it still holds. It's really excellent. You can see the immediate causes, which is reduced food intake and disease, mainly infection. And then the penultimate causes, the household food security, which is the determinant, that is the one that is going to get affected now for food intake, and the care patterns, care of children and mothers. Care means a very broad word. I think we know what it means. And then the actual health organization and the environment, including safe water. So even these might get affected. So all these three might get affected due to the dire circumstances that our country is facing now. And all these would cumulatively cause increase in the child malnutrition. And I think awareness of these problems and this background is not merely for public health practitioners or health policymakers, but clinicians must be fully fully aware of these facts so that they can do their task in a proper context and more effectively. I think especially I want to stress this vicious cycle between poverty and malnutrition. As you can see, poverty leading to low food intake, frequent infections, hard physical labor, these three factors operate. Frequent pregnancies and large families, we have to a great extent reduced. I'm not being frivolous now, but with the enforced rest of the males and more blackouts, I don't know whether that will also change, right? But malnutrition certainly results, and then it causes reduction in productivity for physical labor, indirect loss because of impairment of cognitive function, and the loss of resources due to increased healthcare costs due to infection and other morbidity. And this feeds back to income poverty again. So this is very important. Finally, let's come to the end of my talk. The awareness, what is the role of a clinician in nutrition? He must be fully aware of the full spectrum of nutrition related problems that he would come across. He must be fully aware of the social determinants of their problems and the social construct and the sequelae of these problems. He must be fully competent in assessing nutritional status clinically, anthropometrically, and biochemically. He must have the desire to screen for these disorders within his purview, in the ward. Of course, that does not mean you should jump the gun and make incomplete survey data public and be a scaremonger, but you should be screening for nutritional disorders, looking at the percentage of acute malnutrition in the background in all your admissions. Then you must be completely thorough of the management of nutritional disorders using local resources. I think Professor Pujita will be discussing this today. And then certainly pediatrics is the discipline where clinicians recognize that health promotion or keeping a well child well, as Professor CC taught us, is important. So patient education on nutrition and diet, we can get the cooperation of the medical nutrition trained staff who are in all the base hospitals, but we should be able to do it ourselves. And then we should really have a preventive orientation and should be able to prevent all these problems. And the specific targets we have to be concentrating is on low birth weight, right? Low birth weight, especially by averting stunting and then the care during pregnancy. Improvement of child growth, I think Harendra will be talking about this very in detail. Prevention of anemia, both iron deficiency and folic acid deficiency. Maintaining the low levels of iodine deficiency. Do not let out our vigil, maintaining and screening for hypothyroidism. Prevention of vitamin A, maintaining the mega dose program, maintaining MMN supplements, right? But also maintaining the health education, nutrition education for eating beta carotene rich food. Prevention of obesity, I will not talk more about that. Then prevention of diet related chronic diseases, they are the most important thing. Again, I think Nishani and Pujita have referred to this very recently. The importance of not going for rapid catch-up growth in the infantile period of IUGR children and using the preterm birth charts for preterm babies. Then prevention of mortality due to infection would be the real prime requirement. So I think I would say that there is an excellent article on the current national crisis and public health by Dr. Vinyari Ratna, Executive Director of Sarvodaya and the President-elect of SLMA in the SLMA News. I strongly recommend that you read it. And I would leave you with this parting thought. We are not all in the same boat. We are in the same storm. Some have yachts, some have canoes, and some are drowning. Just be kind and help whomever you can. Thank you.
Thank you very much, sir, for that insightful presentation and also for keeping to time. So without wasting any further time, we will get on to the next topic. And the topic is impact of the economic crisis on IYCF practices. Our speaker is Dr. Hiranya Jayavikrama, Consultant Community Physician from the Family Health Bureau. Over to you, Dr. Hiranya.
Thank you. Thank you. Oh, ඊට පස්සේ එන්න දැන් ඉතින් කියන්නේ එකයි දෙකයි මේ සිකුරාදා නම් මෙයා හොඳටම හිටියා. ඔව් එන මොකුත් නැතුව. ඊට පස්සේ ඉතුරු දවස් දෙක කියන්නේ නාය මේ 7-8 හොඳට ඉඳලා තමයි 9 පටන් ගන්නේ.
Can I request the
Sorry, Professor Heshan, you might have to unmute yourself. I muted or unmute yourself.
Fine. No, I just wanted to tell the audience to mute their mic so that there is less disturbance. Thank you.
Good afternoon.
Hiranya, there's another device. You might have to minimize the sound in the other device and use one device to talk, I suppose.
I'm not using devices.
Madam, there's a certain KMI Subhashini who is turned on the mic.
There's echo going on. Echo going on.
You have to unmute yourself and talk.
Can you hear me now?
Yeah, now it's perfect.
And you all can see the screen.
Yes, can.
Okay, thank you. Good afternoon, everybody. First, let me thank Sri Lanka College of Paediatricians for organizing this webinar. So I have been assigned, I would say, a rather dismal topic considering the current country situation. Therefore, I thought I'll start with a positive note where we were before all these issues came up, because under the Ministry of Health, through the Maternal and Child Health Program, we have been implementing all relevant WHO recommended direct evidence-based nutrition interventions island-wide throughout the country, using the life cycle approach, as well as not only across the life cycle, but across the levels in our health system. We all know we have 4 broad levels where we provide our health services, maternal and child health care services, that is domiciliary care, through the public health midwife and our medical officer of health areas, Then we have field clinic conducted by the medical officer of health, the field weighing post. Then we have the curative sector, the smaller hospitals and referral hospitals. So all these evidence-based direct nutrition interventions we were implementing as per relevance across these levels, and also addressing all possible life stages in the life cycle. I will not go into detail about the data because Professor Narada Varnasurya highlighted about these. So I will skip, but drawing your attention to these stagnant nutrition indicators. And also we see the same pattern from our routine data that we collect through our public health midwives. This is a slide on the annual nutrition month data. Here also we see a similar trend. We don't see a very significant decline in our nutrition indicators. And we have been very ambitious, I think, in setting targets for the maternal, infant, young child nutrition targets 2025 and also Sustainable Development Goals 2030, specifically with regard to wasting. And this current economic crisis would set us back significantly unless unless all of us we get together, not only the health care providers, but also the relevant non-health sector. And when we look at the nutrition status, again, Sir pointed out this very important concept. When it comes to child nutrition, it would be directly the diet of the baby, that is infant and young child feeding, and general child nutrition, feeding, the diet, and also the health status. Those are the immediate causes, and when it comes to underlying causes, we are in a very difficult situation because household food security, it's really getting worse at the moment, and because of our maternal and child health services that we are struggling to provide, care of the mother and the child would be compromised, and so on. When it comes to health, actually we are doing very, very much better compared to nutrition because we have one of the best immunization programs. And according to the Demographic and Health Survey, our infection rates like diarrhea, respiratory tract infections, those prevalences are not that high. However, when it comes to infant and young child feeding, although we are the global best with regard to breastfeeding indicators, however, complementary feeding indicators are not that impressive. If you look at the minimum dietary diversity and the minimum acceptable diet, now this is, mind you, before the crisis, they were not very optimal compared to breastfeeding. And if you look at this analysis, in-depth analysis done by Professor Pulsenarat, in-depth analysis of the Demographic and Health Survey 2016, you would see the dietary diversity, especially consumption of heme iron-rich food, egg consumption, fruits and vegetables. So all those are suboptimal. And also we are very proud of our breastfeeding status. If you further analyze it, there are still issues because the WHO exclusive breastfeeding indicator talks about exclusive breastfeeding among less than 6 months old infants. But if you look at it in depth, you would see that the exclusive breastfeeding rate on completion of 6 months is not that high. So there are a lot of challenges in maintaining the achievements of breastfeeding that we have already achieved. There are a lot of challenges in that, as well as complementary feeding indicators. What we saw before the economic crisis was there was failure to modify feeding according to the age of the child, however much interventions or awareness programs, capacity building that we implemented. So failure to modify according to the quantity, consistency, energy density, spacing of meals, nutrition quality, variety, diversity, there were issues as shown by many surveys. And also failure to modify infant and young child feeding according to the specific growth patterns or nutrition status of the child. So looking at many of our already available surveys conducted by MRI, the Demographic and Health Survey, and many others, you would see, we see rather more than introducing complementary foods too early or too late, even if they start complementary foods at the correct age of completion of 6 months, there are a lot of issues that we observe, like too frequent feeding, frequently giving inappropriate food like biscuits, junk food, and so on, and inadequate quantity, lack of variety, and also feeding technique, which is extremely important. We see force feeding, not so much to indulgent feeding, I guess, but responsive feeding practices also, there are issues. And when it comes to wasting, as Sir pointed out earlier, which has been stagnant for a long period of time, actually it is not concentrated only among the lowest wealth quintile. If you look at this is again an further analysis of the Demographic and Health Survey 2016, you would see that even among the highest wealth quintile, wasting is more than 10%. So responsive feeding practices, feeding techniques may have contributed to this high rates. And even if you look at the maternal education, you don't see a very big gap between the primary or less educated caregivers and the higher educated. So with the economic downturn, we see a lot of challenges in at least maintaining the services and the achievements that we had earlier. Service-related issues are multitude. We are struggling with provision of uninterrupted services, both in the preventive and curative sector, especially due to fuel crisis. Because in the preventive health sector, I mentioned earlier, we provide domiciliary care. We go to the community. We have field weighing posts in the villages. And these child welfare clinics that we conduct, they are scattered around so that the community can reach them easily. So the health staff mobility is affected, and also distribution of essential nutrition items like commodities like micronutrients and triposure and vitamin A and so on. Then we are struggling to generate funds, because earlier government was funding all these services, procurement of nutrition commodities and everything, printing of personal health reports like CHDR. Now we are struggling to generate funds. So there are a lot of bottlenecks in maintaining the services in the health sector. And on the other side, considering the socioeconomic condition in the country, food insecurity is directly affecting infant and young child feeding. Then access to healthcare by the caregivers, reaching the child welfare clinics, field weighing posts, the nutrition clinics, both in the MOH office and in the hospitals, the pediatric clinics. Then caregivers are very much pressurized. Their daily life is very much affected. Job loss, mental stress, all these are going to affect negatively infant and young child feeding as well as childcare. And of course, different sectors and strata are affected somewhat differently, I would say, because rural sector, if they use fuel the firewood as fuel, and if they can obtain a variety of food items from home gardening, the surroundings, neighbors, things are not that bad as compared to the urban poor. So those who can afford, then of course we need to guide them to buy food that are nutritious and low cost. So there are a lot of different modalities that we have to employ in addressing these issues. Now, IFICF guidelines, there are 10 key recommendations. So I have colored in green things that we can promote, we can protect and support irrespective of this food insecurity, like exclusive breastfeeding for the first 6 months and continuation of breastfeeding for 2 years and beyond, which is extremely crucial during this time where we are facing severe food insecurity. And of course, responsive feeding is another aspect. But from number 3 to 9, energy and nutrient-dense complementary food, providing iron-rich food, vitamin A-rich food, increasing the variety, providing appropriate quantities, appropriate frequency. So this is going to be a challenge in an environment where the insecurity is going to be a problem. So some of the actions that we need to concentrate on during this period, I would divide them into direct nutrition interventions, which is the responsibility of the health staff, and the indirect nutrition interventions, the responsibility of the non-health sector. So as I mentioned earlier, promotion, protection, and support of breastfeeding is extremely important during these difficult times. In the hospital setting, ensuring the baby-friendly hospital initiative is implemented fully. And also as healthcare providers, we need to adhere to the breastfeeding code and also the relevant Ministry of Health circulars. That is extremely important. And also intensified community awareness and support to caregivers in maintaining breastfeeding. Then also we provide guidance on how to utilize very limited resources or funds that are available to provide low cost but nutritious complementary food compared to unhealthy, nutritionally poor commercial products and one-pot meals. So guidance is required to our healthcare staff as well as from them to the caregivers and on low-cost complementary feeding recipes. Because I would like to take a minute here to share with you, we have conducted a qualitative study on infant and young child feeding together with UNICEF support conducted by Professor Upul Senarath and his team, and also the Penn State University, USA, where it showed that despite the caregivers having a reasonable amount of knowledge on infant and young child feeding, still they continue to provide various commercial preparations like biscuits, malted milk, sweets in place of nutritious diet, giving in to the child demands and various other issues. So those would get aggravated during such a crisis situation. Then of course it is extremely important that we maintain and increase the coverage of our supplementation programs like the multiple micronutrient supplementation, vitamin A, and provision of supplementary food triposure, and then making available therapeutic food BP100 for the management of severe acute malnutrition. Then continuing and maintaining growth monitoring and promotion program, early identification of growth faltering and trying to prevent the children from going into severe forms of malnutrition, because it's not cost effective and not sustainable to wait till children become wasted and then try to treat them with supplementary food for MAM and therapeutic food for SAM. So prevention is extremely important. So that is why the non-health sector support is extremely important in ensuring food security amongst families with small children. Then also responsive feeding and nurturing care is extremely important during this time. I would like to draw your attention to this slide where it shows that two groups of non-stunted children compared with the stunted children, how the control group fared when provided with a supplement, without a supplement, but stimulation, that is ECCD, and when the children received both supplementation and ECCD, how they achieved almost, closer to the non-stunted group. This is with regard to the development quotient. So it is also extremely important to ensure the ECCD practices in childcare. Then, as I said, as the healthcare providers, the health sector, we can try our very best to ensure that we provide the direct nutrition interventions to counteract the issues that we are faced with. But without the support of the non-health sector, that is ensuring food security of infants and young children, it is not going to work. Food aid in the form of food baskets or cash vouchers is important during this time. And there are community kitchens, and also maintaining and increasing the coverage of the preschool meal programs for 2 to 5-year-olds, then foster care mechanisms, and also cash management at household levels. How to utilize wisely the limited amount of funds that are available in the family, and also promotion of home gardening. So all these to ensure food security in families with infants and young children. So I would like to end by explaining some of the things that, as the Ministry of Health, Family Health Bureau, and other stakeholders within the Ministry of Health is doing to address these issues. As I mentioned earlier, 95% of the funding for our programs was from the government. Only less than 5% was provided by the other UN organizations and other stakeholders. But sadly, now we have come to a stage where we hardly get any funds from the government. So we are mobilizing donor support from UNICEF, WFP, World Bank to continue services like procurement of MMN, and also 3-portion raw materials to continue 3-portion production, BP100 for the therapeutic program, even to print the personal health records like CHDR. Then technical guidance to health staff, how to provide our services in a resource-constrained environment, how to prioritize the target groups, how to target the interventions, identification of target families, children with home risk factors, and also prioritizing nutrition status of children, and also how to modify the infant and young child feeding counseling during food insecurity. Then advocacy for the support that is required to continue essential health services and nutrition services in the community. And we have prepared an emergency nutrition plan together with the nutrition division and other stakeholders. And we are closely collaborating with the non-health sector to continue the school meal program, preschool meal program with the Ministry of Education and Children's Secretariat. And Health Promotion Bureau, in partnership with UNICEF, they are implementing community mobilization programs through the mother support groups in the community. And as we see now, the professional colleges, NGOs, all the other stakeholders have come together to address these issues that we are faced with. So during this crisis situation, prioritizing our services, because sometimes earlier we were providing blanket supplementation, blanket services. Because of the resource constraints, we need to prioritize and target properly our interventions and ensure timely interventions to prevent children from becoming SAM and MAM. And we need to closely follow up and also proper referral when required. And then supportive mechanism for food security. That is extremely important. Otherwise, whatever we do through the Ministry of Health, the direct nutrition interventions, it's not going to be successful unless food security is ensured in families with infants and young children. Thank you.
Thank you, Dr. Hiranya, for that very informative presentation on the problems that we are likely to face with relation to the IYCF practices. I have now great pleasure in getting our next speaker, and he is none other than Professor Harendra De Silva. And Professor Harendra De Silva is the Emeritus Professor of Pediatrics at the University of Colombo, and he will be talking about interpretation of growth charts. Over to you, sir.
I am sharing the screen, but right.
You can say it, sir.
Right. Okay. Let me first thank you, the College of Pediatrics, for inviting me to speak here today. At the same time, I have cut down on a lot of my slides to make sure that I stick to 20 minutes. First of all, I would like to acknowledge Professor Keshan Jayavira, with whom I wrote a book recently, where we shared many of the slides, charts, and ideas. And also the Family Health Bureau for giving me original PDF files of the weight charts. Intrauterine growth is a dynamic process and is an indicator of intrauterine well-being. And then it is monitored in the intrauterine period using ultrasound scans. We all know that. This is basic. And inadequate intrauterine growth would be due to poor nutrition in the mother, placental infections or insufficiencies such as PET, multiple pregnancies, twin pregnancies, chromosomal or genetic causes, as well as a short mother due to malnutrition in mother during the childhood, which is called the intergenerational malnutrition, which Narada spoke about earlier. Measurements are usually useful in its interpretation, and in the Child Health Development Record, the CHDR, which I recommend to use and not to use any other records issued by private sector hospitals. Sometimes it's the same thing, then it's okay, but to use the CHDR. The WHO used a huge sample, which is a reliable cross-section of the world population, and is referred to as the WHO standard as opposed to the Boston standards we used previously. Now, this is for any given population. We know that there is a Gaussian curve distribution of the weights or heights, and then the mean or the median plus or minus 2 standard deviation would be the normal. And this is the WHO standard growth chart, and the mean would be that. And then the 1 standard deviations would be that, and this would be 2 standard deviations. So basically for each reading, there would be a Gaussian curve. And that Gaussian curve would have for each reading standard deviations as well. Now this is for plus standard deviation, and it's the same for minus standard soon after birth, there is a loss of extracellular fluid from the baby, which leads to a loss of weight, which is normal. And with this increasing gestational age, the extent of weight loss will be less. A term infant loses about 5 to 10% of birth weight in the first week, as compared to 10 to 15% or slightly more in the preterm babies. Now, this is not exact. Very often there could be variations, but you have to understand that the weight loss is there soon after birth. And basically the total body weight, water goes down, hence the loss of weight. The extracellular water goes down, but the intracellular water goes up. So hence the reason why we get this reduction. And then can the others mute their presentation, their mics, please? Anyway, so this is what happens in the first week or 10 days, and then it goes up and catches up to the birth weight around 10 to 14 days. Again, it need not be necessarily exactly 10 or 14 days or less. It could vary from child to child. And then after that, the normal growth continues. Now, this is a normal growth chart where you're seeing the growth occurring along the reference line, which is the birth centile. That's the birth centile, and then is going account, which is normal. And therefore, again, it need not be absolutely accurate on the dot. It can vary from a little bit, but you could expect a few ups and downs here and there. But then basically, most of the children will grow along that centile. So that's why it's important to monitor the weight periodically in order to intervene the moment there is an apparent crossing of centiles. Previously, when I did a study long ago, 25 years ago, hardly any of the growth charts were marked at any point. Of course, not this one, the previous one, which used Boston standards. And then, of course, now you would see that there is a sudden, which looks like there is a drop in weight, but then if you monitor carefully, you find that this is just a temporary phenomenon and the child then grows normally. So you don't have to jump in, but just maintain the monitoring to continue. And then this is a child who's growing along the birth centiles, a child who's small for age, and it's going parallel. So I don't think we should need to rush and try to push, I think Narada mentioned this, push this child onto the median or second or first centile. We don't have to do that because that child is normal according to the genetic potential. Therefore, it doesn't happen in the preterm, but in the small for age. Again, another child growing on this line. I think it's good. I mean, maybe a little bit up there, a little bit down there, but basically the growth is along the centiles, which we don't have to worry about. Now, there is something called the catch-up growth, where the child's growth suddenly goes up soon after birth, and then maybe even overweight at some point, but you don't really need to worry about it because then there is, of course, with ambitious mothers, bottle feeding can give rise to bigger problems, but not in the breastfed babies. And of course, there'll be a catch down. This is, the emphasis is not too much, actually too much, but there is a catch down growth effect because when the factors within the womb goes off, his growth pattern will head back towards the genetically determined, that's the genetically determined weight, and the catch up and catch down growths are due to compensatory growth that realigns the child's body size and shape in accordance with these genetically determined path. Now this is at this point, about 2 months to 3 months, there's a sudden fall off. Now that is not crossing centiles to that extent, but then the next recording shows that. So I think that's something which is important to realize. And this downward trend before the stage of complementary feeding may be an early suggestion of inadequacy of breast milk, but which is extremely rare. I think one of the things is that we need to closely monitor when we see a slight deviation, and then advise the mother on the technique of breastfeeding with maybe diagrams and demonstrations and so on and so forth, and also using express breast milk feeding, which could very often reverse this effect, but not before it is too late. Once it's too late, it becomes a problem. So we need to do that. And the need for bottle feeding is actually minimal. And of course, other causes have to be excluded. So this is the point at which it goes off. And this is an early stage where there is waning in crossing of certain times. Again, at this time, I think it's very often due to faulty feeding or psychological issues in the mother. Now, underlying chronic infection could give rise to this type of chart, but I think it's always important to exclude other causes, but to invest and also to investigate for other underlying causes such as chronic UTI and so on and so forth, or diarrheas and so on. And repeated infections can cause a lot of problems, especially if we do not feed the child during infection, and also we don't increase the food intake soon after infection. So now this is a child who's going along the centiles and then suddenly has a sort of maybe a diarrhea or a respiratory infection, doesn't go for about 2 months, and then starts catching up, but then gets another infection and then starts catching up. But what's important to realize is that this is the normal growth pattern that the child should have gone on. And therefore, at the end of a year or so, you are going to see a huge gap in the weight, a big deficiency. And it's not easy to correct that, because if you did not intervene at the early stages, you are going to end up with undernutrition and then subsequently stunting, which is going to be irreversible. Then, if the weights start falling after 6 months, it is due to inadequate complementary feeding. Again, density, feeding practices, and so on is another lecture by itself. I don't want to go into that. And if you have this child going like this, it may be around 4 or 5 months. There may be a need for complementary feeding, but you have to make sure that you don't stop exclusive breastfeeding on suggestion, but sometimes you may have to add complementary feeding before 6 months, but definitely after 4 months, not before 4 months. Now this is another chart. Again, the obesity. If the child is specially bottle fed, it might grow like this. But in contrast to a child who is born big, who will go along the centiles, which may be normal. Now this just graphically illustrates wasting and stunting and underweight. This is a normal child with normal proportions of height and weight. And this is wasting, where the height is normal, but there is wasting, where the weight is less for the height. And this is a child who's chronic stunting, whose weight for height is normal, but his height for age is low. So he's stunted, And this is a combination of acute and chronic, very short, as well as wasted and long-standing malnutrition. Now, this is the weight for length chart, where we look at the wasting. The first 2 years, we use the length, and after that, the height. So this where we use the weight and the length and the height and the weight on the side, which will show you the level of wasting. And unfortunately, although all these charts are in the CHDR, I don't think even 1 to 2% of our pediatricians use that. I mean, even I sometimes don't have time to do that unless it is needed, right? And so on. Now, height for age shows stunting, and the height that is less than 2 standard deviations below the median is called stunting. And once it has set in, it is largely a irreversible outcome and due to inadequate nutrition and infection over repeated or long periods. Now, if you take this, if we take this child at 2.5 years, and then if the height for age is there, and if his previous readings are there, that's normal. And if he's here, again, if his previous readings are along the sundials, again, that's normal. But if you get a weight here, the weight for height for age is here, we don't know where he started. So that's why constant measuring is important, because he starts there, he's there, which is a cross-sectional data. So if he had started at this point, previously we won't know unless we had done it before, right? Then he's definitely getting stunted. Then on the other hand, if somebody starts there at this lower dot, this one, and then goes like that, he's still normal, because he was probably born small for age and then is normal, right? So this interpretation is important, and I think in time to come we are going to see more of this, and we will need the importance of this chart will be more and more. Now, this is the preterm birth chart, which again is not used very often, because it's often not issued to children below 37 weeks of gestation. Now, I have seen so many patients who are born below 32 weeks of gestation who had not been issued this chart. Either there's a shortage of it, or maybe through ignorance of the ward staff that they have not been issued. I think the pediatrician should insist on the issue of these charts, whether it's in the private sector or in the government. The plotting of this chart has to be using the corrected term age. Now, if you are using normal void charts, you need to correct it before that. But in the WHO chart, it's already corrected. Now, corrected age is your premature baby's chronological age in weeks minus how many weeks the baby was preterm. So, for example, if your baby was born at 32 weeks of gestation, she was 8 weeks preterm. If she is now 4 months, which is 16 weeks, her corrected age becomes 8 weeks, which is 2 months. So, in a preterm birth chart, if you chart it, again the same example, you will find it there at the time. This is the 32 weeks, and then at the corrected age is there. So the growth is normal. But if the same example, if you use the normal weight chart without correcting for the gestational age, the birth weight will be marked here, and the 4-month age will be weight will be charged there, and then the corrected age actually would be somewhere there. So I think we need to understand that and do that. I'm sure you all know that, but we don't probably have time to mark these things, and maybe your juniors. Again, this is another example which was actually given by Heshan. A mother with a, now this is the weight if marked in the normal weight chart. But if you do that same child on a preterm weight chart, you're going to get this chart, which is normal. So otherwise, you're going to panic when you see this and take inappropriate measures such as starting bottled milk at that stage. Just final thing is small for gestational age or small for dates. And intrauterine growth retardation. I think we often use it interchangeably, and therefore we need to know exactly what we are talking about. There is a difference in the two. And basically that's the term. And this is large for gestational age, 90th centile. This is appropriate for gestational age, 10th centile. And below that, small for gestational age. Now, this is a large baby, and this is a small for age. I have not put a normal baby there. Now, again, we go on the same standard curves and using the same thing. So, so basically, as I said before, we should not interchange these two factors. This is my last slide, and it shows now this child has been growing on the centiles, birth centiles, intrauterine. And then suddenly the child has some insult, maybe PET in the mother or something like that. And then there is intrauterine growth retardation. So basically this child is born intrauterine, has intrauterine growth retardant, which you will not know unless the ultrasonic measurements are done and used. But at birth, he is appropriate for gestational age because he is within the normal amount. But he definitely has IUDR. On the other hand, this child has been growing normally at the lower centiles up to a point and then has some sort of insult and goes down and has intrauterine growth retardation. And therefore, he is IUGR because of this fall off plus small for gestational age as well. And then this child is going below the centiles, right? But on the normal designated or predetermined line. And he's growing normally. And then, of course, because he is small for gestational age, because this is below this, right? He has no IUGR, but is small for gestational age. So I think we need to understand the differences. It may, some people may think it's subtle, but I think it's important. Thank you.
Thank you very much, sir, for that very clear presentation on interpretation of growth charts. Let us move to the next presentation, and that will be done by Professor Pujita Vikramasinghe, Senior Professor in Pediatrics at the University of Colombo, and he's going to talk to us about management of acute malnutrition. Over to you, sir.
Thank you, Heshan. I hope all can hear me.
We can, sir.
Yeah. First of all, let me thank the President and the College of Pediatricians Council for inviting me to share my experience in this area. At the outset, I would like to say I don't have any conflicts of interest to declare. So my talk actually basically would be based on the management of severe and moderate acute undernutrition, the manual for health workers, which was developed and published by the Ministry of Health in 2019. This is the second edition. The first edition came in somewhere in 2014 or so. So it was distributed among the health workers through a circular in 2020 by the Director General of Health Services. Now, if we just run through quickly some basic definitions, where wasting, of course, is based on the weight for height. If it is less than -2 standard deviations, then we call it as wasted. I'm now concentrating mainly on children under 5 years. And then moderate wasting would be up to -3, and then severe wasting less than -3. And similarly, the stunting would be less than -2 standard deviation, the height for age chart, with severe stunting below -3 standard deviation. Now, we have been using the weight for age chart and try to make a lot of interpretations of that. But actually, we can't make a solid diagnosis of certain nutritional status because weight shows a composite measure of the growth. It has the elements of both. If there is a weight growth faltering, that shows, or the weight faltering, that shows it could be affecting the stunting as wasting and both. So we have to be careful when we are using, but of course, weight for age chart is a good screening tool which would pick up the earliest deviation, especially downward deviations. Now, I don't want to go into detail, but I wanted to emphasize one thing. Of course, the first chart, you can see a child growing normally along the weight for age chart into set standard lines. But what is important is, as it was highlighted, the picking up of these individuals who begin to show some amount of growth faltering at a very early stage. And especially with the exclusive breastfeeding, we do see a minority of children who are deviating around 4 months and 5 months. So if they are not really initially picked up at that point, they really set into a different internal milieu, and their BMR, everything comes into a lower level, and then they sit. So this is actually, if we have excluded other possible reasons like acute infection or something, it could be due to the early showing of calorie deficit between what is supplied by the exclusive breastfed baby's mother's milk, as well as the growth demand made by the infant. This is a very crude, which I have made it into to elaborate the main definitions, where if a child is growing nicely on the 50th centile or the median or whatever inherent line, then we should be able to pick them up the earliest point, which is what we call as the faltering, which will deviate. There will be a growth, there will be a gain in the weight, but of course it is not the optimum rate it happens. Then if they go on without gaining any weight for 3 readings or so, or month, 2 months, then of course we call that as flattening. If we do not intervene that, then they will go into a weight drop. And then only at that point we may get alarmed or whatever, or get the chance to intervene. Then of course, if the correct intervention occurs, then there will be this catch-up growth. So this is not the catch-up growth we are I'm talking about those who are born small or low birth weight, who are coming into a higher level. This is the one who has the potential to grow on a median, but for an acute insult had dropped, or any other reason, dropped in the weight, and then now after rectifying that, getting into this. So this is what we should be able to see in a child whom after we treat for malnutrition. So this was highlighted, and this is one of the most important charts to make the diagnosis of either any nutritional deficiencies from the calorie point of view, whether it's undernutrition or overnutrition. So after we have understood that the individual has some faltering, we have to go through this process where we try to find out the reason, because how much we try to acutely treat the person will not do the best unless we do the justice by treating the underlying reason for this. So we have to sequential look at the availability of the food, which is going to what we are going to foresee in the near future. Then of course the other medical issues like ingestion problems, digestion, absorption, increase in loss or increased need due to demand. Then one of the main things what we see here is, even in when we were seeing fair reasonable amount of foods in the backdrop of reasonable food security, that there had been improper feeding practices, especially when the complementary feeding was started. During that period, we can see improper main meals, non-nutritive breastfeeding, because there is still a lot of on-demand breastfeeding that happens at that time, which may hinder the small stomach filling with adequate calorie-dense food items. Then the underlying illnesses could be there, and also micronutrient deficiency, especially with, we know the only flip thing or the only disadvantage, if at all, with exclusive breastfeeding is the dwindling of the iron stores. And iron, of course, causes a huge impact on the nutrient intake because it drives the respiratory cycle. And then when the respiratory cycle begins to comes down, the energy cycle, then the individual will sits into a low energy requirement consumption, reducing his appetite. So having said that, what are the main determinants of successful treatment would be depends on the time of presentation. As I highlighted earlier also, before they adjust themselves metabolically, we should be able to pick them up. And then, of course, as in any condition, the compliant to treatment is the main thing. So how do we pick them up? It's mainly we are happening at the public health midwife level. But of course, we know a sizable proportion of individuals today attend the private sector. And actually at that point, it is very, very important that it is because most of the pediatric practice, the weight will be measured, but seldomly it will be plotted on the chart. So it is very important that most of or each and every measurement enters or ends up in the CHDR. As Professor Harendra highlighted, it is without knowing what happened in the past, it's very difficult for us to just in a cross-sectional data interpret that. So it's important that, and then of course height or the length at least once in every 6 months if we could measure and plot it. And at that same time, the weight for height also, or the length weight for length chart is updated. Then of course, these deviations could be picked up very early, which is very important. So having said all that, if we go into the management and how do we handle a child who comes with severe wasting, where we have detected them based on the weight for length or weight for height chart who are below -3 standard deviation. So if we do the preliminary analysis and we see a child is fairly good in appetite, clinically well and alert, and most of this group of individuals would be who are coming with maybe some other illness or who are coming for the routine evaluation that had not been really appreciated by the caregivers. Then if these properties are there, most of them could be managed in the home setting or the outside setting. So that means they could be labeled as the severe wasting with no complications, and then they could go into the outpatient treatment. So the summary of outpatient would be the feeding, of course, with partial therapeutic feeding depending on the circumstances. Then, of course, you have to provide them with the basic health care. If you don't practice proper hygienic practices and things like that, then, of course, there will be no use of treating them because they will go back to the same cycle again. And then the other thing is the nutritional counseling, because we try to maintain most of them not only on therapeutic, but because therapeutic feeding would be only for a transition period. And after that, they have to go on with the normal healthy diet. So then to ensure how to make health food security, how to ensure that they would do the right choices, all that is also part and parcel, because it is not only curing like a illness, which will one-off thing, it is actually a recurrent thing. So if we don't correct the background, I don't think we will be doing our duty properly. So then on the other hand, there may be individuals who have very poor appetite. They may be nauseated, vomiting. There can be intercurrent illnesses. They may be severely anemic. There could be high degree of fever with dehydration, lethargy, non-active, like that, any other medical condition. Of course, they are with the complications of, could be directly related to the wasting or could be intercurrent, but of course, they are not suitable to be managed at home because they can go into worse situation. So those are the ones that will need in-house management, where especially the medical care for the underlying problem, and then of course to go on with the feeding, which is the therapeutic feeding. So if we look at the inpatient, so if we severe a child with severe acute malnutrition gets admitted, these are the life-threatening emergency things which we have to sort out very quickly within the first few hours of admission. So we have to make sure that there is no hypoglycemia, hypothermia, dehydration, there are no electrolyte imbalances and infection. And so in that view, we can organize our basic investigations, Plus, we should continue with the monitoring of the individual. And then one important thing about the management of the dehydration is because most of them are having relative hypernatremic dehydration. So they are dehydrated not because they have profusely lost because of fluids and electrolytes, because they have been improperly getting and they have been losing a lot of water through evaporation and not been taking. So they have a hypokalemic, relative hypernatremic state in their solution, in their intestinal fluids, in their body fluids. So because of that, using the ORS have to be done carefully. So as the patient is in the hospital, careful monitoring of that can be done. But of course, special preparations have been made, which is called rehydration solution for malnourished child, which is called Rosomel. Of course, this is a commercial preparation, although it has been sort of ratified and distributed by WHO. And you can see the electrolyte content is low sodium and high potassium compared to the old and the new versions of the WHO ORS solution with some added micronutrients. Of course, I just put this slide and this preparation because people have heard, but of course, again, they have high commercial cost and all that. So if we just make sure that we ensure that we don't let the child goes into hypokalemia, because we should not be complacent that once we have started the rehydration, okay, everything will be sorted. No, we could push them into a little bit of hypokalemic state. So it is important that we watch them. We may be able to provide them with some degree of potassium supplements, or the other solution, the easy solution is the king coconut water or even coconut water to a great extent as a local solution. So for completion of sake, I have included this, but I don't think this is available, and I don't think we should be fighting to get this because there are other priorities at the moment or at any moment to this country. So moving on to the next stage, once it comes into the latter part or right from the beginning, after attending to the immediate complications or the impending complications, then you have to also make sure we start on the feeding as well as provide with the micronutrients. So iron, as we know, we don't supplement them in the initial phase, but of course the micronutrients, especially B group vitamins as well as the other minerals, including zinc, need to be introduced because they are used in most of the other as coenzymes in the metabolic processes. So if we provide the energy, there will be not proper utilization or complete utilization of that if we don't provide them with the other coenzymes. So that is where it has to come in. So going on to more detail of providing the calories, we have to make sure that we provide them a relatively low osmotic load, because now they may have been starved for a reasonable period of time, and then they are their villi, the intestine may be in an atrophic state, so they may not be able to handle the large osmotic load. So that's why we use usually 100 milliliter, 75 kilocalories in 100 milliliter solution. Although we have again commercial preparation F75, because this has now almost people know it like that, but of course the simple basics is you provide a 75 kilocalorie in 100 milliliters, which is of course if you take a milk feed, a normal formula milk, if you dilute and add a little bit of sugar, then you almost get that preparation. Only thing is these commercial preparations have a little bit of added other micronutrients, which of course you can very easily provide with the other multiple nutrient supplements. So you begin with that 70 to 80 kilocalories, about 100 ml per kilo per day in divided doses, in divided feeds, 2 to 3 hourly intervals, depending on the ability of the child to take it on. Sometimes they may have low stomach volumes, and in those cases, you may have to give them as even a drip feed, because if you give a large bolus for fluid, they may tend to vomit. Then gradually you can increase it to about 130 milliliters per kilogram per day. Then may have to use NG feeds if the intake is excuse me, if fairly low, especially if it is less than 80% of the total intake. Then of course the micronutrient supplements. Then once we do this initial management, we will be moving on to the second week onwards, where we can add a little bit of iron as well as we begin to increase our calorie intake. And then of course the important thing is you should not try to expect a growth in the first week or two, because they have to establish themselves. They may be losing a lot of edema fluid, and there may be a loss of weight also in the initial phase. So I think looking at a weight gain in the second week onwards would be the more prudent thing. Then of course iron supplementation, by now you may be knowing that the hemoglobin level, and if that is normal, of course it is only supplementation, usually given as 3 milligrams of elemental iron per kilogram per day as a single dose. But if the anemic state is there, usually in this age group it is 11 grams per deciliter, the cutoff value, you have to treat them with 6 milligrams per kilogram per day iron till they reach the hemoglobin normal level. So although the anemia could be due to any reason, but in a child like this, it's commonly due to iron deficiency, and you don't have to actually do other sophisticated iron tests, but even not need to do a ferritin level. What you can do is if we treat with adequate amount of hematinics, and after 4 weeks if we repeat, and if we see a 1 gram per deciliter rise in the hemoglobin, we can take it as a diagnosis of iron deficiency. Especially if the RDW is high, more than 16%, we can really judge them as iron deficient. But in my own experience, of course, even a 0.8 gram rise, I take it as a positive for iron deficiency anemia and continue the treatment. So usually I would recommend them to give the iron in 2 divided doses, because iron is a very, very metallic taste mineral. So it is not pleasant to intake, and then many children will refuse. Furthermore, it will be intervened by the dietary intake. So giving it into 2 divided doses would ensure much more better absorption rather than giving a single dose. Coupled with vitamin C as well as folic, and also a zinc containing mineral is better. But of course, we have to space it out at least 2 to 3 hour gap between these. So not to give the zinc preparation also with the iron, because the zinc will get competed and may not get properly absorbed. Then of course, after the hemoglobin has restored for about another 2 to 3 months, we would continue the supplement dose to make sure that the iron stores are replenished. So on the other hand, the vitamin A, you can provide with the supplement all children if they have not received anything within the last 1 month or so. Vitamin A mega dose 100,000 units could be given, and afterwards also make sure that monthly dose are repeated. Then of course, if there are any symptoms, you treat them with the doses usually given on day 0, day 1 and day 28. But after 14 days, the third dose could be given at any time, and the doses vary depending on the age of the child. So now we have given the micronutrient supplements, we have started the calories, and now the child will gain appetite, his metabolic processes, BMR begins to kick in gradually, and his demand for food will go up. So once his demand goes up, to provide the required calories, the volume provided by a 75 kilocalorie per 100 ml will not be adequate density. So we may have to move on to a higher density, dense food item. So that is where this F100 preparation has come. Again, there is no rocket science here. It is only 100 kilocalories in 100 milliliters, or 1 ml contains 1 kilocalorie. So then we can go up to about 150 to 120 milliliters per kilogram. That is a fairly high kilocalorie rate per day, and you can give it at a 3 to 4 hourly interval. If we set, because we also have to make sure that feeding is not the only thing. There are other activities like cuddling, adequate sleep, stimulation. Those are also important for the growth of the child. So that has to be given adequate room in between. So when the calorie density keeps on increasing and the amount that can be fed with 100 with F100 may not be that easy. So you have to go for higher dense, calorie dense food items, and that is where the ready to use therapeutic food come in. So with time, with the demand and the requirement increases, the RUTFs could be increased with the slowly taking away the F100 or the liquid food items. So once we go into the second, third week, we can make an evaluation. If there is more than 10 grams per kilogram per day weight gain, then of course that is very good. But of course, if it is less than 5, then of course we have to rethink. We have to see whether we have missed something and really thoroughly investigate these individuals. So failure to response is labeled as if they have failed to gain appetite by about 4 days, failed to lose edema or edema persisting after 10 days, or failed to gain this much of 5 grams per 5 grams per kilogram body weight in 3 consecutive days. So once we have done this, and if we see everything is going on, we also have to make sure, as I said, right from the beginning, stimulating of the child should be also there. And once we have come up to a stage where, okay, the child seems to show improvement, then we also have to make sure that the bystander or the caregiver is empowered to look after this child at home. So the participation of that introduction of all these activities that had done and what he or she should be doing at home should be outlined during this stay. So once the things are quite moving in a positive manner, the required weight gain is there, and there shows upward movement of the weight, then of course we can prepare the child to be discharged and follow up as an outpatient. So the appetite, if it is good, at least more than 75% of the prescribed RUTF is being ingested, medical complications are controlled, edema is minimum, and then more importantly, the caregiver is quite competent and confident to take care of the situation at home front would be the other crucial thing to determine. So once they are going into the outpatient, or the ones who have been initial stage detected as fit to be managed as outpatient in the community, the assessment would be that you have to make a good assessment. They have to be registered in the clinics, and then we have to assess the caregiver also to see whether the ability of feeding is there. So if the caregiver as well as the food security is good at home front, then of course we can opt for 50% of the calories with normal diet or normal food and about 50% with the RUTF. If not so, and we are not happy, and there is a chance that there can be shifting down again back to worst state, then of course initial stage we can make them 100% for some time. So try to provide about 200, close to 200 kilocalories per kilogram per day, and with the combination also only with RUTF. Then we have to make sure that the medications, if we are giving, are intact, are given. Then definitely the vaccinations have to be fulfilled, and then the supplements of vitamins and minerals have to be ensured. So we have to teach them how to use the RUTF and try to improve the intake of the family foods in the same time. So the basic healthcare education has to be done to prepare in the food management of the illness and prevention of the diseases, and especially the RUTF should not be shared with the other members of the family, because that is what had been seeing most of the time, especially with the Triposha program. So this has to be clearly stated, and RUTF is given for the medical reason, and that is for the SAM, because once they have moved out from SAM to the MAM situation or the moderate acute, RUTF will be stopped. So initially, of course, the follow-up period, although I have said here as weekly, it may be the first visit and weekly or the second visit, but hereafter it at the discretion of the two parties, where if the compliance is good and if everything is happening, 2 to 4 weekly intervals we can see them. Otherwise, depending on the state, we have to review them in the clinic. And if there is no improvement, or if there is a weight loss, again, they have to be referred back into the medical, or if they are totally being looked after, cared in the outpatient department, but there is no proper weight gain, then of course they may have to be managed in-house or investigated and see for the real reasons which would have been missed by now. So if we start from the lower end and then keep on going, so once they have crossed the -3 line, that is from red to yellow zone, they have moved, then of course we call them as MAM. So the reduced therapeutic food introduction will be stopped, but they would be introduced into the nutrition rehabilitation program like the Triposha program, which has a high calorie density of about 400 kilocalories per 100 grams. And with that, so, but of course, the 3 main meals with the homemade prepared food, family food should be given, with mainly concentrating on the supplementary foods as the snacks. And then we still follow them up. We don't discharge them because we have to make sure that they don't take another U-turn and drop back into the original state. So we continue, and even when they pass -2 standard deviation, you still follow them up. So then, of course, the supplementary food, roughly about 350 to 500 kilocalories we try to provide, and we try to mainly provide them through the food provided as 2 to 3 snacks, where we concentrate on the main meals with the family food. And then we continue that even beyond -2 standard deviations, where now they are no more undernourished. However, there is a danger that they could fall back. So complete discharge from the program is only when the weight for age goes beyond -1, or if there is increase towards the weight is increasing, or the weight for height length is increasing, directed towards -1, and then they have kept on going, but not reach -1, but of course is above -2 standard deviation for the last 2 months. So if they have been hovering in this area, but has not reached this -1, if they had been going upwards for 2 months, of course, then we have can consider them as a positive follow-up. Of course, once in about 2 to 3 months, you can get them down and supervise them. And then family counseling is very, very important on how to maximally use what is the available resources to prevent them from getting into undernourished state again. And as well as management of the underlying illnesses. So this is a quick look at the reduced preparations, which were these 2 were introduced in this country. But of course, we saw that the BP 100 had a much better acceptance than the peanut-based plum peanut preparation. But you can see the calorie density for 100 grams, or here 92 grams having 500. Here 100 grams have 527. So the main advantage is that it is a dry product, so it does not need refrigeration, and the storage and the shelf life is fairly long. However, because it is a fairly dry product, it needs to be provided with, or the individual have to be provided with adequate amounts of liquids or fluids whenever this is being given. So that has to be ensured and told the parents that there is a farm, and the guide of course has given the volumes, how it has to be given and all. So coming on to the last slide, how on recapitulating what I have said over the last 20 minutes, where the individual will be, once he or she had been identified to be wasted with a weight for height less than or weight for length less than -3 standard deviation, they would be either with complications or without complications. If they have complications, of course, they have to have been in patient management, medical care with therapeutic feeding, with low osmolar initially, and then go into the high osmolar, high calorie dense solutions. The outpatients, or the ones who are now fit to be discharged or now recovering, could be go on to outpatients or where the feeding with reduced therapeutic foods and the other nutritive food items in the household, and then also provide them with the basic health care. So then they would reach on to the moderate wasting stage, where the weight for height will become -2 to -3. standard deviation, then they would be taken off from the BP 100 feeding, but they would be introduced into the other nutrition rehabilitation program, either Triposha or CSB or whatever available material will be given with other nutritive support as well as the follow-up. So the follow-up will not be stopped at that point, and the total discharge would happen only once the weight for height goes beyond -1 standard deviation in the weight for height chart, or between -2 to -1, and had been there showing an upward trend for the last 2 months. So that is the basic way we are usually managing. But thank you.
Thank you, sir, for that very comprehensive presentation. We will now move to our final presentation, which is on the burden of micronutrient deficiencies in Sri Lanka. And this will be presented by Dr. Renuka Jayatissa, who is the head of the Department of Nutrition at the Medical Research Institute in Colombo. Over to you, Dr. Jayatissa.
Thank you, Professor Ishan, for the introduction. I'm just trying to share my slide. First of all, I would like to thank Professor Guanilianige, President and Council of the college. Can you see my slide in the kind of presentation mode?
Okay. Not yet, madam, but we can see the message. Can, madam? Yeah,
I have to really rush. That's always the case for the last speaker. I will try to finish very quickly. So my topic is the burden of micronutrient deficiencies in Sri Lanka. So it's a huge topic. So I thought I will just start with the very basic slide. All of us know about this slide, but I just want to emphasize about the importance of micronutrients for the essential cell function, as well as 3 elements which have been embedded with the micronutrients, that is vitamins, minerals, and trace elements. So when we look at the micronutrient, there are mainly two types, and the type 1 and A2. What is the difference between these 2 types are the type 1 actually, which will show us the specific deficiency signs and symptoms. So as a result, like vitamin A deficiency, which we can see it with the beta spots, like that there is a specific signs. But in type 2, the important is it will affect the growth, but we don't see much specific signs. Now, as an example, like zinc, we know zinc will lead to stunting, but stunting is not always due to zinc. So as like that, so this is which is important in the micronutrients. So as a result, there are 2 important definitions which are related with the micronutrient, that is micronutrient malnutrition and the micronutrient deficiency disease. So this MDD is the one that you always handle, but it is important in this crisis situation to really look at the micronutrient malnutrition. So where that actually people may appear very well fed, but still they may be suffering with the kind of life-threatening malnutrition and the debilitating thing, as well as they might not ended up with their kind of micronutrient needs. So which is what we call it as a hidden hunger. And then the MDD is, I think that's what in the hospital, what you see and what you treat. And when we really look at the burden, so this is my topic. So when you look at the burden, and this is a thing to show that I think our last micronutrient survey was in 2012, which is very old now. Currently, we are doing an assessment, and we can provide the data most probably at the end of this year. According to this 2012 one, we have a very progressive reduction of anemia prevalence. It was at 15% in 2012. But at the same time, you can see the kind of prevalence in the different districts, so which is very much important, especially in this type of economic crisis, how we can prioritize a group, how can we identify the people who can really need the real kind of interventions. So you can see even 2012, Monragal, Polonnaruwa, Trinco, and Kilinochchi, these were the districts which had very high level of kind of anemia, which was kindly indicated as a very high public health significant level. So then let's go into the diet adequacy. I think Professor Narada has shown this kind of research publication, but in that which we did just before the economic crisis, that is last December. Here you can see the children under 5 years, 6 to 59 months, the inadequacy of their diet for the micronutrients. You can clearly see calcium has become the top inadequate in our diet, that you know because of the kind of inappropriate educational messages and everything which was hampered to this level. And then as even the globally, even that the 4 kind of major micronutrient deficiencies have been really alerted. Those are the vitamin A, iodine, iron, and zinc. Even you can see in Sri Lanka also, it's a similar kind of thing, but happening. But this is another publication. I just want to show you this is a dietary reference intakes for the Sri Lankans. So it was really kind of compared with the dietary reference intake, with the children diet is really reaching that level. This is another one that we had to think about the adverse effects of micronutrient deficiencies. That is, I think I don't want to really tell you because you know as clinicians all of this, but I just want to emphasize a little bit again in this economic crisis situation, because we have to expect the susceptibility to infections increasing and the adverse birth outcomes, growth stunting, lower capacities, cognitive capacity, mental retardation, and the final one is blindness. I don't think it will happen to us. I just wanted to show you one of the slides I had to show. I think I had a kind of word with Professor Narada. So after that, I thought I should show this. As clinicians, calcium deficiency is always, you know, about the rickets and that part, a skeletal one. But in this slide, I just want to highlight the other part of it, like stunted growth, because even currently we are having the kind of around 15%, like 13% now, the current stunting rate. Still that we are pushing the children from the stunted to the normal group. So this period, if we get the calcium deficiency also, it will be further delayed. So this is something we have to really think about whenever we are giving the advices. It should be really appropriate for the time setting. Then in addition to that, when we look at the current context, what are the kind of contributing factors? All of us know we have a problem with the harvest. We have the problem with the unemployment and income, and there's a huge issue with the purchasing power. And at the same time, food supplies are interrupted due to fuel shortage, and we have a limited access to fresh foods and the lack of food diversity. Even I think higher income group has also really gone to that type of situation. And we have to think about the deterioration of nutritional status, and at the same time, it will end up with the outbreak of diseases and the other causes of malabsorption. So these are the contributing factors we have to think about in this current context. In addition to that, there are so many other contributing factors in Sri Lankan setting. You know, food security, we always talk about food security. The real definition of food security is we have to provide the sufficient, safe, nutritious food to meet the dietary needs and food preferences for an active and healthy life. So it is a big words. The pre-economic into last December, almost 1/5 of the households in Sri Lanka were food insecure. And the estate sector, it was almost 2/3 of the households were food insecure. So this is the start of economic crisis, what we were. Then the other thing is cost. Now there are 3 type of diets which has been really recommended by the FAO. There is depending on the quality of the diet. First one is the energy sufficient diet, that which will provide us energy only. And then there's a second type of diet is nutrient adequate, because it has a kind of essential nutrients. But the third, what all of us has to really reach the healthy diet, because it will really relieve the deficiencies, as well as it will provide the diversity, and it will really relieve the NCDs also. So when we have estimated the current cost of the diet with the food prices. To provide the energy sufficient diet, we need about, for a family, they need about 12,500 a month. You know, usually our low income category, they are the whole thing. I mean, they are the kind of monthly income is very, average monthly incomes comes about 15,000 rupees per month. And the healthy diet, in the current one, in the basic healthy diet, we need about, for a family of the 5 people, need about almost 63,000 per month. So this is the current cost. So you can see that how many people can afford this type of diet in Sri Lankan setting. So in addition to that, we had to learn some lessons from similar countries like us. This slide is from Venezuela. They were upper middle income country. They were a little upper than us also. And all of you know that Venezuela is a very good country. They had everything, but they had the same crisis like us, dollar issues as well as fuel issues and everything. So when they started the crisis, the malnutrition was something less than 5%, and now it has gone up to over 20%. At the same time, in that context, we have to see what are our poverty lines and the poverty groups in Sri Lanka, what are the most affected districts in Sri Lanka. Currently, this is the latest census data. According to that, highest kind of poverty in Mullaitivu district. Then after that, which comes the mainly estate-bearing districts like Nuwara Eliya, Badul and Ratnapura. And the other districts are also falling with that. Then why these are important? Because these are the districts when the malnutrition will come up early. So this is very much important for this screening and the kind of doing these all interventions in as a first place. And this is another slide I just want to emphasize because what will happen? Now, normally when there is a shock like this economic crisis, for the optimally the children who are already malnourished. So what will happen to them is they will, in the early childhood, they will grow below the potentials. But if they get the little bit of kind of interventions, they can really get the rehabilitation and get the recovery, but still they don't grow up to the optimum. So this is what very important, but Professor Narada and Professor Harendra, Professor Pujita, all were mentioning about the screening. So this is something we have to really identify the children. Screening is very much important, and the early intervention. Then what are the predictions for Sri Lanka? With all these available data, what will happen to us? One of the our prediction is we will get with the severe malnutrition will be double. Now 35,000 children are in Sri Lanka, so it will be double. And then the micronutrient deficiencies, especially iron, vitamin A, calcium, and zinc. These are the very key micronutrient deficiencies we will expect in our children. And the other malnutrition expect in the pregnant women under 5, children 10 to 15 years also kind of very key one, and the elder, especially above 70 years. It will be very worse, and the most vulnerable population will be the people who are below the poverty line. Currently, it is 14.3% in 2021 were below the poverty line. It will expect to increase it to 30%. And the state population and the urban underserved population. And even currently, we are assessing the quality of diet of people. 70% of the people have informed us they have reduced the consumption of the most expensive food items, and the 80% have mentioned that they have reduced the size and frequency of meals, and even the another 80% mentioned that within the families and the adults they prioritize their children's food consumption over their own. So this is what currently happened in the Sri Lanka, because we are currently collecting data, and these are the responses we are getting from the people. In this type of crisis, these are the recommended nutrition interventions. These are global recommendations. Today, I think we have addressed almost all. So I am just addressing the micronutrient deficiencies and all the other things. Actually, it is a very good webinar. We addressed almost all these interventions today. So when you look at the micronutrients, so we have the kind of range of food, at least, I mean, we should really include 5 food groups. These are the essentials in our kind of food. Now, what is happening down, like now most of the people are eating rice and the one curry or one kind of malum or something. But all these 5 food groups should be in our kind of the daily food to get the adequate quantity of micronutrient. Now, children 6 to 59 months, actually, we have been really trying to support, and we have developed this low-cost recipe for the complementary feeding for younger children, which will really give parents to give the idea, and we can really share it with all the pediatricians. Then you can always use it with all the children and the mothers who come to that. Other thing is, we have been really looking at the now Triposhi, 1973, MRI has developed, formulated, Dr. Bright Dimel was a pioneer, and they developed this Triposha, the situation like this. But now Triposha is out of our access, and we have developed another kind of cereal, which all the kind of, this is, I have put it here. That because looking at what are the deficiencies at the moment, and we have added the fortified this cereal product into the with the vitamins and minerals which are most essential, giving at least 50% of it, and then can develop as the soft porridge. Even for the one of the things why we develop is for the tube feeding also. We are trying to, because nutrition clinics, about 45 clinics are in the country now. We want these MO nutrition to do the kind of screen these kids who are coming to OPD, just coming for their sickness. These are kind of missed opportunities. And then I think today I'm very happy Professor Harendra has really mentioned how to use this flow chart and how to identify the children correctly for the intervention. And then they can be given the correct targeted intervention in such a way, rather than kind of overusing the things. And the other thing is, the other global recommendation is multiple micronutrients. And in Sri Lanka, we have multiple micronutrients, but sorry to say that about only 25% to 40% coverage of DVC, because it is not really used by the parents properly. So this is a time for the need, a lot of advocacy and kind of necessity to show that people that it is something very needed for this period of time. And what are the other kind of options to prevent the micronutrients? Especially when the food assistance rations are given for the families, like vulnerable families, by the government, it should be included with the nutrient-rich commodities, and the provision of the fresh food items, especially with the general rations. And the other thing is provision of fortified food. This is very much important. And even like the World Food Program and them, they are trying to provide the food rations and everything. Then we have to really advocate to provide with the certain amount of necessary fortified food. And the other thing is especially facilitating the dietary diversification with the exchange or trade, because when the home gardening start, exchange is one of the very good things to do. And the other thing is zinc. Currently it is there, but I think it is not really utilized properly. We have to really advocate for that. And as I mentioned you, the MMN, and the other thing is home gardening. Now it is very popular, but we have to really look at what are the things to be really grown, and everything we can't grow in everywhere. So this is some of the posters we have utilized to show that these are the kind of very quickly grown vegetables to be used. And the other thing is raising community awareness is something very important. They need some visual posters, flyers, and everything to improve their practices. And another part why that we are having this much of micronutrient problem, even with the fresh, with the huge greenery in Sri Lanka. So these are the other things we had to think about. This is our Sri Lankan food composition table, which is, you can really get it from us. And it has all the commonly consumed food items in Sri Lanka. What are the available micronutrients and what is the quantity and everything is in that book. So anyone can really see whatever, habaralakolo, anything, what is the amount of micronutrient in that. But in addition to that, with our cooking practices, we have to think of some of the things like heating food, which will reduce the nutrient content. Now, like thiamine and everything, usually in the bread, 30% less than the raw ingredients. And the processing reduce the micronutrient content. That's what the white rice versus brown rice that all of us know. And the storage of micronutrient-rich food, usually losses are high within the first 5 days post-harvest. Even the refrigeration also, some losses are there. Then you need the appropriate storage and packing. That may be the dehydration and the vacuum packing. And the solid dry and green rich vegetables and the yellow fruits, mangoes, and they increase the vitamin A content. So these are another good tips. And the frying and fermentation also decrease the vitamin A in food by 25%. Long cooking time destroy kind of vitamin C, even the folic acid. Steaming in a covered pan preserves the nutrients more effectively. Then the covering and cooking is another kind of part. And the vitamin C and iodine are water soluble, and it is can be lost by throwing away cooking water, because some of our cooking practices are we throw away the cooking water. So all these things have been affecting our micronutrient loss during the cooking, because sometimes in the book says this much of vitamin is in the this leaf or this food item, but we might not get it because due to the processing and cooking. So all these things we have to really think of. So what is our way forward? One thing is we have to really have to go for the multi-sectoral nutrition emergency plan, at least for the 6 months plan. And the most important thing is community and the hospital screening for severe malnutrition. At least, this time the resources are strained and the fuel is a crisis, and at least using the MUAC tapes, you have to screen and then do a proper assessment, and then do the appropriate kind of management. And the other thing is policy decisions, especially the currently low-income people are mainly use this nadu rice and the white kakulu, the adding kind of key vitamins and the minerals into that. And the other thing is a blanket supplementary food for estate children. The other part we have to think about this urban underserved population, low-cost canteen. I think these community kitchens are coming up. So these are the good signs. And the other one is in the seawater fish, sea fish. I don't think it will be very cheap in the future because of the fuel price and everything. So the other option is the freshwater fish in tanks, because in Sri Lanka, about 3,500 tanks in the country. So this is a good time to have the freshwater fish and then popularize those things. At the same time, because of the fuel crisis, a lot of the transport system has hampered. Even in the future, the food prices will go up because of that. Then the food preservation at village level, dehydration, packing, vacuum packing, and then the coming through the train system and reach market, then it will be very easy for the kind of easy in the sense it will be good for the pocket of the consumers. And the other thing is in the home gardening, we should not really deal very big home gardening, but everybody should have something 40-day green leaves and the 40-day something vegetables to kind of complement their meals. And the other thing is one of the important thing when we look at the calcium and things, we have to think about the milk and the curd production and the promotion and the make it available. And especially now the transport issue, then the making curd and the having the thing is the most important thing rather than milk, because otherwise it will be more expensive. And manioc, yam, and sweet potatoes, I think it can't be, they can't replace our rice meal, but because of that can reduce the rice quantity and mainly for adults. So these are the kind of way forward for the things if we want to improve our micronutrients as well as other nutrients. So my take-home messages are adequate micronutrients are key during the first years of life, essential, so which is very essential to focus on any crisis. And in early childhood, the need for essential nutrients like iron and zinc and the essential amino acid is very high due to the growth. So therefore, we have to really think about providing the micronutrient-dense food items. Diversified nutritious diet is key to provide the required micronutrients, and especially when in the difficult to obtain, we have to really think about the fortified food and especially for the poverty groups. So thank you very much. I hope that I kept I am within my time. Thank you, Professor Shesha.
Thank you very much, Dr. Jayathi sir, for that very timely and update presentation. So we have come to the end of the 5 presentations, which were of very high quality and very up-to-date presentations, where we have actually looked at all provisions in relation to nutrition and its challenges. So